afternoon, everyone. I'm Kristina from and today I'll be talking about LV thrombus after non-STEMI. So acute myocardial infarction and non-ischemic cardiomyopathy may lead to the occurrence of left ventricular thrombus. The incidence of LVT is decreasing due to early reperfusion techniques. And usually the more extensive the myocardial injury is, the higher is the risk of developing LVT. Usually LVT is following patients with STEMI, and it can happen in 43% of the cases. However, LVT development after non-STEMI cases was not at all in 5% of the patients. And here we report a case of LVT after non-STEMI. So our patient was a 71-year-old female with a medical history of hypertension who presented to ED with a typical chest pain. Her vitals were showing basically regular tachycardia, blood pressure of 140/60, regular respiratory rate of 18, and saturation of 97% on the room air. Physical exam revealed also regular rate and rhythm, no murmur, gallops, or rubs, no GVD appreciated on physical exam. And EKG showed ST depression in the lateral leads. Troponin was also elevated, 2.1. TTE demonstrated apical hypokinesis and a large mobile irregular mass on the septal wall, highly suspicious for LVT. Next step was to confirm this with TEE, which also demonstrated apical thrombus, diffuse hypokinesis, and estimated EF of 35%. So we made diagnosis of LVT related to non-STEMI. We started patient on systemic anticoagulation, and it was weight-based enoxaparin to achieve the goal of INR of 2 to 3. And then the patient was discharged and with outpatient follow-up to assess the elimination of LVT. And here we can see also echocardiogram showing the picture of apical LVT. So myocardial infection can lead to imbalance of Virchow triad factors due to reduced ventricular motion, local myocardial injury, and hypercoagulability. Transthoracic and transesophageal echocardiograms have high specificity but low sensitivity in detecting LVT. And cardiac magnetic resonance has the highest diagnostic accuracy. Current guidelines suggest management with vitamin K agonist for 3 to 6 months and are initially co-administered with parenteral anticoagulation due to its initial prothrombotic effect. However, the high risk of the embolic event remains after the resolution of LVT and potentially may lead to stroke or other cardiovascular events. So direct oral anticoagulants can potentially be a safe and efficient alternative to VKA. However, there are no actually randomized controlled trials to confirm this. And our conclusion is that LVT is a rare form finding after non-STEMI in the reperfusion era. Although not expected, it can occur in patients with non-STEMI, and this case highlights the existing lack of randomized trial to determine the type and duration of anticoagulant therapy for the management of LVT. Thank you, and if you have any questions.